So welcome everyone. We will be slowly starting right now this session. Welcome to this first webinar of the year of the World Medical Association Junior Doctors Network Antimicrobial Resistance Working Group. My name is Dr. Pablo Estrella. I'm a medical doctor from Ecuador. I'm also a public health and preventive medicine specialist in Spain, and I'm chairing the Junior Doctors Network as well as co-chairing this working group with my co-chair, Dr. Olayinka. So Olayinka, would you like also to introduce yourself to start the
Yes.
webinar?
Thank you very much. Hello, everyone. My name is Olayinka Fakuridi. I am a Nigerian medical doctor. I currently live in the US where I work as a public health researcher. And I also serve alongside with Pablo on the JD and AMR working group. So I'm excited to be here for this webinar and I look forward to having a great session.
Thank you so much, Olayinka. And probably before even starting with our guest speakers, which we are really excited to talk about, I wanted to give you also some brief introduction of why we are here. So antimicrobial resistance is one of the top global problems that we are already facing globally. And as Junior Doctors Network of the World Medical Association, we have taken this topic really serious to ourselves. Therefore, we have junior doctors from across the globe that have joined our working group, and where we're trying also to have different initiatives on where junior doctors can play a key role on working towards antimicrobial resistance topic. One of the key areas that we're also part of as JDN is we are part of the quadripartite working group on youth engagement for AMR, which is joining 14 different youth organizations from across the globe, and together with the four quadripartite organizations, WHO, UNEP, WOA, and FAO, we're working together also of bringing different opportunities to youth. From our side, from a Junior Doctors Network, we've been discussing already since last year with our members that one of the key topics that we wanted to focus more as junior doctors is the role of strengthening antimicrobial stewardship. And of course, this goes by hand with building those foundations and engaging with global surveillance system, as well as what's the focus from a national perspective. So the objectives for this webinar, we will want to define also the core principles of antimicrobial stewardship. We will recognize also the critical role of junior doctors in establishing and advancing stewardship in hospital, clinics, and communities. We will appreciate also how the GLASS, this global surveillance system, and national surveillance systems inform prescribing practices, and as well learn from this country-specific experiences in antimicrobial stewardship and AMR surveillance. So without any further ado, I will let Olayinka also introduce our first speaker.
Thank you very much. So we're getting right into it. And our first speaker is going to be Deborah Tong, and she will be talking to us about the antimicrobial stewardship, just an overview to start with, and then an overview of the existing WHO tools for implementation of stewardship interventions at the hospital and clinical level. So I'm going to read Deborah's bio now. So Deborah Tong is an infectious diseases and antimicrobial stewardship pharmacist with postgraduate qualifications in global health policy. She is currently the technical officer for antimicrobial stewardship in the Department of AMR, Division of Health Systems, Access and Data at WHO in Geneva, Switzerland. She has over 14 years experience in designing, implementing, and evaluating antimicrobial stewardship programs at the local, national, regional, and global levels. Deborah's professional interests include developing data-driven and context-specific antimicrobial stewardship policies and programs to improve health equity in resource limited settings. So we are really excited and honored to have you here today. So I'm going to give the floor to Deborah now to speak to us on antimicrobial stewardship.
Thanks very much, Olayinka, and also to Pablo for the invitation. I guess I will share slides from my end. And give me 1 second. Okay, can you see that in presentation mode?
Yes, we can see it.
Okay, perfect. So I was asked to give a bit of an overview of what antimicrobial stewardship entails, and then what sort of tools and resources are available from WHO's side to help clinicians, including junior doctors, in implementing stewardship in their own settings. And that's where the WHO Aware system will come in. So I'm just going to combine the two topics, and happy to take some questions at the end if there are any. So, as a bit of an overview and understanding as to why we need stewardship, as we all know, as clinicians working with patients, antibiotics are one of the key essential medicines that we have, and we need them all for all facets of medicine. We need it for basic healthcare, including simple wound infections, skin and soft tissue infections, urinary tract infections, pneumonia, and other more serious infections like bloodstream infections. We also need antibiotics for appropriate maternal and child health, including some infections that are becoming increasingly difficult to treat, like gonorrhea, as well as to ensure the health of preterm babies, as well as mothers that experience complicated deliveries. We, of course, need antibiotics in modern medicine to prevent and treat infections that arise from things like joint replacements, transplants of organs, as well as cancer chemotherapy. But what we know is resistance is emerging very quickly. This is a rather old figure, but it does demonstrate basically for different antibiotic agents from the time that they were introduced, which is the yellow dot, through to the time that the first reported emergence of resistance to that particular agent was described. And you can see for the vast majority of agents, particularly the ones that were marketed in the last 50 to 60 years, basically, as soon as an antibiotic is introduced to the market, resistance is already observed. So even though we may have agents coming out, very quickly, acquired resistance already develops. And on top of that, we at WHO over the last 7 years or so, every 2 years we do an analysis of the clinical pipeline, which is basically an analysis of the antibacterial agents that are currently in development or just being approved. And the last report was released last year, and it's a little bit busy with all the different bars, but essentially what we know is that the antibiotics that we do have, especially the ones that are considered innovative, meaning that they have a novel mechanism of action and they don't have cross-resistance with other antibiotic classes, these antibiotics that we currently have in development, combined with those that have recently been approved, are still very much insufficient to tackle and treat the number of drug-resistant infections that we are currently seeing. And so what does that mean? When we have antibiotics that, where there's emerging resistance coming out very quickly, as well as limited number of new agents, it means that there is a greater risk of treatment failure. There are more people dying, and this is coming at a much greater cost to our healthcare systems, both at a systems level and to the individual level. And this basically summarizes the number of global deaths that are attributable to different diseases or areas of concern. And you can see for AMR, it's basically around double the number of deaths that are attributable to it compared to other very common diseases like breast cancer, HIV, and malaria. And when we look at the number of deaths that were associated with AMR, this number becomes even greater, almost 5 million deaths, which were associated with AMR in the year 2021. So that comes to the global efforts that are being put in place and underway since the last decade or so. And you will already, I'm sure, be quite familiar with the Global Action Plan on AMR, which is currently under revision and update. But even with the update, there will remain a very firm pillar that will be focused entirely on optimizing the use of antimicrobial medicines. And the reason for this is because the inappropriate and overuse of antibiotics in particular, but antimicrobials in general, is a key driver of AMR. And so this is where antimicrobial stewardship comes in. And at WHO, we define this as a set of coherent actions which promote the responsible and appropriate use of antimicrobials to help improve patient outcomes across the continuum of care. So you can see here there is a specific focus on not only preserving antibiotics for future patients, but also to improve the outcomes of the people and the patients that we have right in front of us today. And what this means is that we need to make a proper and optimized diagnosis using clinical judgment as well as any other tools that are available to us, and only prescribing antimicrobials when they're needed and not using them for example, viral infections or for simple bacterial infections that would be able to resolve on their own. And if and when antimicrobials are needed, choosing the most appropriate choice of antibiotic or antimicrobial, the most appropriate dose, including the dosing interval, as well as the most appropriate route of administration and duration of treatment. So all of this is encompassed within antimicrobial stewardship principles. And why is it so important? We have evidence, although the majority of evidence does come from high-income countries and more so in healthcare facilities, for example, hospitals, rather than the primary care setting, but increasingly there is more evidence in different settings. But antimicrobial stewardship does help to reduce unnecessary antimicrobial use, and as such, has reduced selection pressure and also reduces the emergence and spread of AMR. We also know that it preserves the usefulness of our existing antimicrobials because we simply do not have enough new antibiotics and antimicrobials to keep up with the rate of emergence of resistance. It helps to improve clinical outcomes of the patients that we have and to improve the safety and quality of their care, and helps to enhance cost savings and cost benefit within the for the purpose of the patient at the individual level as well as at the societal level. And so that brings me to the actual principles of antimicrobial stewardship. And I think this slide nicely summarizes what it means to incorporate antimicrobial stewardship into your day-to-day practice. We call this at WHO the 8Ds. And hopefully it's an easy to remember list of 8 considerations that you would have anytime you are thinking about prescribing an antimicrobial for a patient. And that includes, as I mentioned before, having an appropriate diagnosis. And we don't need very fancy diagnostics for this. I think having the time and ability to take a history and do an examination and make an appropriate clinical diagnosis already does 80 to 90% of the job. There are, in some circumstances, where diagnostics or laboratory tests could be useful, particularly more in the secondary and tertiary care levels. But in primary care, in the vast majority of situations, your clinical judgment is already more than sufficient to make a clinical diagnosis and to make a decision as to whether the patient actually has a significant bacterial infection or not. And so that will help you with the next point, which is the decide of the D. So this you would consider if antibiotics are really needed. And as I mentioned before, there are many circumstances in which patients may have infections that do not need antibiotics, and this includes very common upper respiratory tract infections, which are generally viral in nature, as well as other more minor, even if they are bacterial infections, are minor or could be resolving on their own. For example, lower UTI in females. Antibiotics are not indicated in certain situations, as well as minor skin and soft tissue infections, which are able to be resolved on their own. And another consideration for the decide step is whether you should or need to take any cultures or any other tests to help you with your clinical decision support making or decision making. The next is, if you have decided that antibiotics are needed, which one should you prescribe? And I'll go a little bit more into detail about the AWARE system and what the Access, Watch and Reserve antibiotics refer to. But in general, what is the antibiotic with the narrowest spectrum that can target the most common or most likely pathogens causing the patient's infection? And then are there any other considerations on the patient side or patient factors that need to be taken into consideration? For example, specific allergies, drug-drug interactions, or other comorbidities that the patient might have that may predispose them to certain toxicity or side effects. Once you've decided on the drug, at what dose should you prescribe it and how many times a day, or what dosing interval should we be using? And any specific adjustments that need to be made to the dose based on renal impairment, hepatic impairment, or any other considerations. Then the delivery, or what we generally call the route of administration. And in the vast majority of circumstances, and where it's appropriate, where the patient doesn't have a deep-seated infection, generally the oral formulation is what is preferred. It's safer, it's cheaper. It allows the patient to be treated in the community or in primary care. And even if intravenous treatment is started and needed, when is it appropriate to actually step down to oral? And then another consideration is the duration of therapy. Again, for stewardship, in terms of stewardship principles, the shorter the duration of therapy, the better. How do we actually calculate this? If the patient's starting on intravenous treatment, it would include both the intravenous treatment as well as the oral. Quite often you find, it's easy just to say 7 days of treatment or 10 days of this, but in actual fact, the minimal time that we can expose patients to antibiotics, the better. And then the last two Ds, I think, are the ones that are quite often missed, and they are to discuss and inform the patient of what diagnosis has been made, what sort of duration of symptoms to expect, any side effects to look out for, and any red flags if they experience, ongoing fever or certain signs or symptoms that they should come back and see a medical professional. And then lastly, to document and to write down all the decisions and your management plan in a place that is accessible to all the caregivers of this patient. So I know I spent a little bit more time on this slide, but I think this really nicely summarizes, as a clinician, what considerations you should always consider in the back of your mind when you are treating a patient with a potential infection and need for antibiotics or antimicrobials. So that brings me to the WHO AWARE system, which is a global toolkit, if you like, of lots of different resources and tools that are available free of charge online for the purposes of implementing antimicrobial stewardship in different settings. So I'll go through them a little bit one by one. You may have heard of the AWARE classification. So AWARE stands for Access, Watch and Reserve, which is basically a categorization system for antibiotics that are used globally, with the intention that it's kind of formulated like a traffic light, in terms of green being go, yellow or orange being be careful, and red being stop. The idea is that access antibiotics are the ones that are narrowest spectrum and are considered first or second line for most common infections that we see. These are the ones that are narrower spectrum with less impact on the microbiome and less likely to drive resistance. And these are ones like, I'll show you on future slides, but then we have the watch, which we use less of, which is the middle of the triangle. These are broader spectrum, more expensive, more toxic agents. And then you've got reserve, which is the tip of the triangle, where we aim to use the least of these and preserve their usefulness for infections that are caused by multi-drug resistant organisms. And I will also mention the not recommended group, which, aside from the Access, Watch and Reserve, are labeling products that are fixed dose combinations of multiple antibiotics or antimicrobials and don't have specific evidence to support their use. And I'll go through them in a little bit more detail. So as I mentioned, the access group antibiotics are your narrow spectrum agents that should be made available everywhere from primary care through to tertiary and quaternary care. And you can see on the right-hand side the ones that are currently on the WHO essential medicines list. And you can see you've got the narrow spectrum penicillins like amoxicillin, benzopenicillin, as well as first generation cephalosporins like cefalexin, cefazolin, tetracyclines like doxycycline, aminoglycosides like gentamicin, amikacin, and some others that are quite frequently used in primary care like sulfamethoxazole trimethoprim, metronidazole, etc. Then you've got the watch antibiotics, and these are the broader spectrum ones that are more likely to drive resistance. And you can see the third generation cephalosporins on there, like ceftriaxone, cefotaxime, macrolides like clarithromycin, azithromycin, as well as quinolones like ciprofloxacin and some broader spectrum agents like meropenem being a carbapenem, or some beta-lactam, beta-lactamase inhibitors like piptaz. We see globally that watch group antibiotics are far overused, both in the primary care setting as well as in hospitals, and quite often they are used in place of other more appropriate interventions. So, for example, using them as surgical prophylaxis when it should be the technique and environmental cleaning that should be more emphasized rather than using broad spectrum agents to try and prevent infection. And so the watch group antibiotics really are a major target for antimicrobial stewardship programs as well as initiatives. And we see quite a lot of watch antibiotics being used in many different settings, particularly agents like ceftriaxone. Then we've got the reserve group antibiotics, which I think I will have already described a little bit, but as I mentioned, they should be restricted to specific indications and patients that have serious infections that are caused by multi-drug resistant organisms and for which the access and watch antibiotics are not suitable. And so you'll see these are the ones on the WHO essential medicines list. You've got the newer beta-lactam, beta-lactamase inhibitor combinations, as well as some older agents which are still or coming back into favor because of a lack of treatment options. So things like colistin and fosfomycin, which has been around for decades, fell out of favor because of toxicity or because of cost, but are now coming back into use because of their activity, especially against resistant gram-negative organisms. And maybe just to note here, in some settings, particularly low and middle income countries, they still do experience some challenges in access to reserve antibiotics when they need them, which is a particular area that we are also trying to work on. So that also brings me to the not recommended antibiotic group, which was the brown box in the top right corner of the other slide. And basically, this is when you've got combinations of antibiotics or antimicrobials which really shouldn't be used together, and there's no good evidence or robust guidelines to support their use. And you can see some examples in that table, but quite often you get beta-lactam like a cephalosporin combined with a fluoroquinolone, or two penicillins in the same product, or a fluoroquinolone with an antifungal, for example. And so there should be no clinical indications for which these combinations would be generally used. And WHO provides guidance on not including these antibiotics in national guidelines, formularies, essential medicines lists, etc. But unfortunately, as the way it stands now, many countries still manufacture and market and use these not recommended fixed dose combinations. And maybe before I move on to the next part of the AWARE system, I think the AWARE classification itself is really a good tool that can help clinicians at the local level to, for example, implement restrictions in in the prescribing, dispensing, and administration of antibiotics. For example, in hospital antimicrobial stewardship programs, many have a type of restriction where the narrower spectrum access antibiotics may not necessarily have specific restrictions on their use, but watch antibiotics like third generation cephalosporins or fluoroquinolones, you may have to satisfy certain criteria before it can be prescribed or dispensed by pharmacy. For example, it has to be concordant with guidelines that the facility uses. And you may, as an AMS team, be focusing much of your stewardship efforts on reducing and improving the appropriateness of the use of watch antibiotics. And then reserve antibiotics could be the ones, for example, where you need pre-approval from your infectious diseases specialist or from your AMS team or the hospital manager in order to actually prescribe it. So that's just a way in practice how the aware classification could be used at the local level. And that will bring me to the aware book. So as you know, the classification itself is really just a list of antibiotics and what category they belong in. But it doesn't actually provide much information and guidance on how to use those antibiotics. And that's where the antibiotic book comes in. So this is a combination of quite a number of years of work, and it's available in a number of forms like the physical book, some infographics online, as well as an app, and it basically provides guidance on the use of antibiotics in different common indications and infections that we see in primary care and hospital. It's available in a number of different languages: English, Spanish, French, Chinese, Vietnamese, Bahasa Indonesia. And maybe in the interest of time, I won't go through the case, but just to highlight, this is what an infographic looks like in the aware book for community-acquired pneumonia. And you can see provides some of the epidemiology, the most likely pathogens, what sort of microbiology tests would be appropriate, any other diagnostic tests or imaging. Then it gives you information about a scoring system which you can use to determine the severity of community-acquired pneumonia. And then it gives you treatment options for mild to moderate cases, as well as more severe cases. And you can see that in general, access antibiotics and oral antibiotics are prioritized more for the mild to moderate cases. And then it's intravenous and watch antibiotics that are indicated for more severe cases. And then I will also touch on another guidance document we have, which is the Antimicrobial Stewardship Practical Toolkit, which is now getting updated to incorporate a few additional features, but is available online in its current form, which helps users to implement stewardship at the facility level. And then also now there are some e-learning courses which are free and available on the WHO Academy. I've put the two titles of the courses that we currently have, one on the practical toolkit and another which is more based on a national policy guidance, but could be still of interest to those working not just in hospitals, but at maybe a public health level. So I will stop there, just in the interest of time, and back to you,
Yes.
Pablo, and yeah, thank you.
Deborah, thank you so much. This was super insightful and I would say also super practical as well. So this is exactly what we were also looking for junior doctors, where we are trying to see how from the concept we can actually apply directly into the clinical practice. So for sure, all these resources you have shared would be super useful, and we will check on questions for the panel discussion. Now, I would like to welcome our next speaker, Professor Dr. Narendra Saini. He's a professor of microbiology, former Secretary General of the Indian Medical Association, Chairman of the AMR Committee of the Commonwealth Medical Association, as well as the Indian Medical Association, convener of the Commonwealth Alliance of Medical Professors on AMR, convener on the National Alliance of Medical Professors on AMR, assessor on the National Accredited Board for Hospitals in India, principal investigators in the Indian Medical Association AMR Smart Hospital Project, and pioneer in AMR, organized several AMR awareness campaigns across India, invited speaker in several international national conferences, and leading news channels as an AMR expert. So we're really honored also to have you, Dr. Saini, here. And for your section, we would like also to have now the national view. With all your experience, we would like also to know how clinicians and junior doctors can engage with national AMR surveillance systems to improve prescribing practices, but also to strengthen antimicrobial stewardship at the local level. And based on your experience also leading AMR initiatives in India, which practical lessons or examples you can also share with our fellow junior doctors. So the floor is yours, Dr. Saini.
Thank you so much, Dr. Pablo and Dr. Ola, for giving me the opportunity to speak in front of such an august gathering. And I think my talk is perfectly placed when after the talk with Dr. Tong, who described, we always say in medical professions, structure, process, and outcome. She has described beautifully what should be the structure of AMR stewardship program, antimicrobial stewardship program. The processes she had explained. Now the question comes of implementation. There's always a challenge in implementation of these things. Things are there, and I think you people are really fortunate. I will not call you as a junior doctor. I will say to the young doctors. In India especially, I will say the young doctors are the face of medical profession because they are the people who are seeing, if I talk about OPD, if I talk about uh, the patient who are admitted, patient in the casualty, patient in the ICU, the young doctors, which you call yourself a junior doctors, are the face of that. They are seeing the maximum number of patients, or they are the initial responder to any ailment which is there with the patient. So here becomes very, very important, young doctors, uh, especially for antibiotic stewardship program. They are the one who are going to prescribe antibiotic. They are the one who should know when and when to prescribe these antibiotics. Once this is done, I think it is very difficult to then come back again. So very, very important for you to people understand why so is such thing is important. So coming to this, you have already told about me. So challenge how to move from the global, which is glass, and from to a national program, and then at a local level. So there are these three processes are there. So how a junior doctor or a young doctor has to accustom to all these things. So there has to be we have to improve as she has already, Dr. Tong has beautifully described the problems which we face because of AMR. We don't have any new antimicrobials. We have to preserve what we have. So this important is how, as a junior doctor or a young doctor, I am going to prescribe my medicines. That's so important now. So improve prescribing accuracy, strengthen local hospital stewardship, because I may have data, but how to strengthen, how to make my people to write what is required, not just based on assumption we are writing. So build a repository of actionable clinical strategies. That is what is required. Already we know about glass, so it is at a global level, which is, I think, at my level, I talk about 40 years back, we were not even talking about antibiotic. It was just which antibiotic to write. Today we are saying that when to prescribe. Previously it was which antibiotic to write. So it is important that we have come to a stage where we have to see which antibiotic, whether the antibiotic is necessary or not. That's a very, very important issue nowadays because we don't have any new molecules in the horizon, as Dr. Tong has already described this. So, national level in India, the national level is ICMR, Indian Council of Medical Research, that is driving the AMR program, ICMR, along with NCDC. NCDC is whenever there is a outburst of infection, then the another body which is there at a national level is NCDC. Then we have a local program also of hospital antibiogram. And moreover, I will say this local level NABH is a organization which is for the quality of healthcare, which accredit hospital for quality. They are the one who monitors NABH, and now IMA has also, I will tell you in the latest, the Indian Medical Association is also working on how to sensitize our doctors regarding the antibiogram and how to prescribe the rational use of antibiotics. So local antibiogram, I will say the local antibiogram is so important when we are writing our medicine. Maybe at a national or global, at a global level, the data is coming. No doubt that was very helpful, or this data is coming only from a local level. So the local antibiogram is very, very important. The quality of a local antibiogram is also very important. That this is an issue in most of the developing countries because the quality of antibiogram is so important. How you are doing a culture, when to we are doing a culture, what antibiotic we are prescribing, how the culture is being done, how we are reporting these culture reports, they become so important in having having a very quality type of a antibiogram. This is, I think, this is an issue. This is a problem. So, am I audible?
Yes, sorry,
Hello.
one mic open from the participants. That's solved.
Okay, fine. So this is a very important, and in India it is working at a national level, it is working at a ICMR level or a NCDC level, and a local level, their state AMR program also, and a hospital own antibiogram is also there. They are all contributing to a national ICMR. But the important, as I said, important is how the data is being collected. What is the quality of antibiogram which is generated globally, I will say. But if I talk about my country, I will say that yes, some hospitals are doing a great job, but more quality is driven data is required in these cases. Then is how do then is this what it tell us when we are talking about it? Provide standardized metrics of priority pathogens. So we have a list of antimicrobials. We are not taking antibiogram when we are talking about from a glass level. Only few of the antimicrobials, we are taking about the bacteria which are causing infections. We have a limited number of primary pathogens on which we are working on. So, but it helps us in knowing what is coming up. If the doctor should see this global glass level also, that what is the antibiogram which is coming, because it is telling us that when the storm is coming, we are seeing colistin resistance in South Asian countries. So that again give us that how we have to prescribe antibiotics. Are we unnecessarily writing antibiotics? How we have to do it? So it is important that we must check regularly the glass annual reports and also our national report. And at the same time, I will say another important thing when we are talking about antimicrobials is we have to um, we have to talk about the infection control practices also. During my journey in these years working on as a microbiologist working in India and elsewhere also, I have traveled to Commonwealth countries also. I realized the infection control practices are also very, very important. Don't allow the infection to come. So there will be no antimicrobials required. So infection control practices are really, really important. And now what we are seeing is high prevalence of ESBL organisms. So there is MDR Acinetobacter is coming up, which we have seen in Indian tertiary care hospitals. Uh, we are starting what is the issue, becoming that because certain hospitals have reported that there are a number of ESBL or MDR producing. So start away, we are starting with the third generation of cephalosporins. In spite of antibiogram is giving us a different indication that we can go around, but because the issue in the press and all these things and pressure of the patients and our own presumptive things, we are now moving towards third generation cephalosporins. These are important to understand that please go to the objective elements. Yes, everywhere there will be MDR organisms, but it does not mean that we should change our prescription habits based on all these things. This has to be based on local antibiogram. And now I think I just, in the previous speaker, Dr. Tong has said that WHO has given a watch list, aware list, sorry, aware list. We should be aiming towards access 70%. Unfortunately, we found 70% is taken by the watch group of antimicrobials. So that is from what is being we are aware of it, but when it comes to implementation, we are doing the reverse. It is 70% are in the reserve group. So sorry, in the watch group. So from access to watch, we have to really work on that. We have to really change our minds in all those things. We are trying to do this, but I think more such kind of awareness campaign is required. And as I said, the young doctors are so important. They are going to bring that change. Once they write it, or once they object to it, nobody is going to write. Once they start writing it, seeing the seniors, then it becomes difficult to change. So you can bring the change. So very rightly said, garbage in, garbage out. If without proper diagnosis, without proper, Dr. Tong described 8 Ds, so important when you are prescribing antimicrobials. If all these things are not taken care of it, so the garbage in, so what will happen? The results will also be totally not expected will come out. And secondly, the antibiogram which we are talking about, that will also be of no use because this will be giving us all pictures which we do not want to have. So culture, the important thing is culture before you give antimicrobials, adequate right site, right time, also important, which 8 Ds which are important. Then is reliable diagnostic tools, which are very important. That is sometimes become a challenge in country like us. Diagnostic facilities are so important, especially for culture. But sometimes we found that India has progressed, many of the developing countries has progressed, but still the culture is not done everywhere. It is a challenge. And for prescribing antibiotics, so important. We always talk about the culture is so important. So it really hampered the quality of data, the quality of culture report also if do not have accredited labs. In India, we have labs for accreditation purposes. They are NABL accredited lab. NABL accredited lab means they are quality driven laboratories, access for that particular purpose. But in many of the accredited lab, also the culture is not being done. So this is a challenge in the country, that how to propagate more of culture facilities, and that too a quality-driven culture reports, which are so important when we talk about antimicrobial resistance. We are talking about antibiotic stewardship. All this becomes haywire if we do not have a good quality labs. Then is uh, this is showing bacteria are sensitive to specific antibiotics. So there is an antibiogram. If you see, the interpretation of this antibiogram is so important. We have certain number of times we have seen the challenge which we are talking about. Number of times that because it comes after 48 hours to 72 hours. I being a NABH assessor also, I have seen number of times if the patient is on a third generation's phylosporins and the sensitivity is coming of the first generation also, nobody is changing it. Nobody is rather seeing this because patient is getting all right. So we continue with such kind of antibiotics. So these checks and balances are so important. Or sometimes when we see in the local antibiograms that certain antimicrobials are not showing a sensitivity, but in the presumptive treatment when we start, we continued with such kind of antimicrobials. So these are very, very important. And here, all these things, the young doctor can make a difference, because the senior doctors come and only talk to a junior doctor what is the report and all those things. If a young doctor tells that the report is such and such, then okay. But if the young doctor doesn't know that what is important in that report, what is the culture report, if he says only that this report is showing the sensitivity to a drug which we have already given, whether it is third generation or even if it's colistin, but it's showing to a lower antibiotics, the same continues. Escalation, de-escalation, which we are talking about, is never being discussed when we are taking rounds. So it's so important. So again and again, I emphasize, you people are the one who can drive a change. Very important. You are the eyes of the senior doctors. If the eye doesn't see, then you can very well judge what a senior will do. So a patient, we just talk about 48 hours review in ICU. A patient is started on meropenem empirically. Junior doctors proactively review. This is a very good person. He sees a blood culture at 48 hours. That no, there is another which is second generation. So he start and de-escalation is happening. But this happens very few times. It doesn't happen most of the times. So this is where the challenge comes. Sometimes knowing things, but we ignore it. That's so important if we want to bring a change. So stewardship is not about denying antibiotics to sick patient. It is about refining them based on data and avoiding collateral damage. Then another another which we are very fond of is this audit of a medical college and a private hospital. This is a finding. I'm giving you a real picture sometimes, and maybe you all are working in different hospitals. You will also find the same. This is my experience while seeing as an NABH assessor going to different hospitals. 90% of post-op patients were receiving a antibiotic for full 7 days, even if it is not required. We can de-escalate it. The data shows that it's not infective in nature, but we keep on giving. Like in surgeries, we talk about prophylactic antibiotic. There are two important things in a prophylactic antibiotic. One is, as per the policy, which antibiotic you have to give, at what time you have to give, and at what dose we have to give. But every surgeon has his own whims and fancies and they give it. And the time is not checked. A time is so important because that shows at what time the drug level will be high, so that when the incision is given at that point of time, the level of the drug is high. But nobody cares about it. The timing is never been care of. And everybody is giving their own choice of antimicrobials. So what will happen? The resistance will spread. And then they keep on continuing this antimicrobials in a clean surgery for a period of time of 6 or 7 days. So we really have to work on that. We are trying to work on this. I will show you what we have trying to do. I'm giving you simultaneously what is happening and what we are doing also. It's just example. Excess watch. So I'll just skip this because we have already talked about it. But in India, in our country, we are working on to reduce the number of watch group of antimicrobials, which are prescribed more than 60%. We have to come to a WHO level at an access level that these antibiotics should be given. But at the same time, we have to see the antibiogram also, which is so important, national antibiograms. So do not just read the sensitive or resistant report. You have asked for a culture, but you have to simultaneously see what are the other parameters. Urine culture, there can be a normal flora also. The sensitivity comes. So lab is so important. Whether to report antibiogram or not in that case. And even if the lab has given the junior most doctor, the young doctors must know whether this anti-sensitivity antibiogram which has come, whether we have to give this antibiotic or not. It has to be correlated with the microscopic examination of that urine also. So important. One must have a license with microbiology. So this is again a challenge. Microbiologists are few in numbers. Mostly it is labs are pathologist driven or biochemistry driven. Very few labs have microbiologists. So this is another challenge where microbiologists can really talk about minimum inhibitory concentration or how to report even the antimicrobials, how to report sensitive and resistance. There's no role of 3 plus and 2 plus kind of a sensitivity. It has to be either sensitive or resistant, or whether if the coming even if it coming as a sensitive or resistant, whether the antibiotics are required or not. Many number of times there is a colonization of bacteria. This is a challenge which we face. Number of times our young doctors are writing even on the base of a culture. They do not realize that the patient is suppose the patient is on a catheter. There will be colonization of bacteria, whether this antibiotic is to be given or not. How to correlate this antimicrobial antibiogram with the clinical symptoms of the patient. So important that we have to judge the clinical symptoms of this. And the solution will be we should have at least a WhatsApp group. Wherever we are writing culture, we should write in that group where the clinical microbiologist or some senior doctors are also there, so that this is discussions happen, and then we start giving antimicrobials. We have to come to a stage where we must, whatever antimicrobials if we are writing, there should be some discussion platform. So there are pressures. There's another important aspect which we have seen in I think in most of the countries also must be. There's a pressure from the I will say from the patient also, from the society also, that uh, give us antimicrobials. The pharmacists in India especially are giving antimicrobials. No doubt the law is there that antimicrobials can't be given by a pharmacist without prescription, but they are being given. So implementation of law is also very, very important. So again, sometimes because of whims and fancies, so awareness about antibiogram amongst the population is also important. You can show that the objectively driven data can give us the guidance that yes, and I can defend it also in front of the patient that no, you do not need an antimicrobials. This is the data which is showing that for such kind of illness, you do not need it. You must have all seen that during the COVID time, so much of antimicrobials were used when they were not required. So there is a WooNet software is there, but again I found amongst our doctors very few, our labs also, there is a lot of hindrance in using the WooNet. Rather, sometimes many times the people do not know. So such kind of awareness programs is also required for our doctors. So volunteers I will say the volunteers are needed from the IT department to help us in putting the data into WooNet or such kind of softwares, so that we can get better antibiograms, better results in a digitalized manner in a fast manner on our platform, so that we can prescribe antibiotic in a nicer way. So again, I said the limited diagnostic facilities. And another important thing in our country is and being because the doctors have less time. They can't have all the things because number overcrowding is there. Number of patients are more. This is a challenge. But I think more number of now doctors are coming up. more number of hospitals are opening up. In due course of time, this will be taken care of. But at the same time, again, we have to, even if the overcrowding is there, if you have the data-driven things with you, then it will really help you at least not prescribing antibiotics. Now, what is happening is, so patient coming fever, so one antibiotic has to be written as a protocol. But this is set in their mind. This has to be changed. That's why this data from national AMR data or from data from glass is so important that our young doctors should go into it and read it carefully, and curating and the awareness to be created at a government level also, and in the hospital also. Another important aspect in India is, and most of the countries will have, we have more private driven hospitals are there. 70% are private hospitals, and there the the data mostly is collected from the government setups. So this is another challenge, because sometimes we feel whether that data is important, that data which we are getting through a national program is really will be helping us or not, because most of this data is from the government institutions. So this is another challenge. So Indian Medical Association, we are working on that. We are bringing more private. Indian Medical Association is asking the private institution to come and give the data to us so that we can drive this moment from our side also. Then this is what we have done in the Indian Medical Association, WHO Civil Society Task Force on AMR we created with WHO. Then we have a dual tier alliance architecture. We collaborated with national. There are different specialist organization in India. So we are collaborating with these national specialist organizations, which are 52 at present. We are collaborating with them, sharing this AMR program, antibiotic stewardship program. We are driving on that. Then we have a alliance with Commonwealth Medical Association also. So Commonwealth countries, we are also working with them, sharing our data, taking their help, how to drive it. And we are pleased to inform that London resolution on AMR, when we had a conference of CMA, we declared there, and we'll share it in a different platform with all of you. So multi-stakeholders engagement we are doing with Niti Aayog is another one important health care organization which is working on the issue of antimicrobial stewardship. As I said, NCDC, NABH, Ministry of Health. So Indian Medical Association is working on that and finding solutions to our problem. We have seen one thing which is there, that roughly around 400 prescriptions per thousand are having a prescription of antimicrobials, antibiotics, which should not be there. So to 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 for this, we started a program called AMR Smart Hospital. That is, I think, a very, very innovative program started by Indian Medical Association, that is called AMR Smart Hospital Projects. It has objective elements, different objective elements, which are based on NABH standard, and Indian Medical Association has coined certain more standards into that. In this, the hospitals which are applying, they have to go first. They have to show the training of the hospital staff, which include the young doctors, senior doctors, and their hospital staffs in terms of antibiotic prescription, and more importantly, in terms of the infection control practices which they follow. So there are objective elements from the antibiotic stewardship program. There are objective elements from the infection control point of view. There are objective elements in terms of housekeeping point of view, CSSD point of view. So through this, they are being checked at the desktop assessment. Means the person doesn't, assessor is not going there. The hospital is providing the data to the office, and then later on, it is an on-site assessment where the assessor goes and check all the things in an objective manner, whether the things which are there being implemented properly or not, whether surveillance is happening properly or not, whether the implementation of all this, whether the key indicators which are required for giving this kind of a certificate to this as a smart hospital, whether they are there or not. So especially we check on the young doctors, the prescription audit is happening. Antibiotics are prescribed based on the antibiograms or just on presumption basis, and whether de-escalation, escalation is happening. It is serving two purposes. One is implementation of the program, and secondly, putting in the mind of young doctors that it is so important. Antimicrobials to be are very, very important part of their prescription writing. And thirdly, it is driving the hospital to go towards infection control, better infection control practices, and knowing the importance of aware classification of drugs. At least people have started knowing all these smart hospitals, AMR smart hospitals. Now they know the importance of aware group of drugs, and having a performer for restricted group of antimicrobials. They know hospitals whom we have accredited can write reserve group of graphs without putting a different form and getting a signature from a senior. That's become a mandatory for that program. So we are, uh, as I said before also, diagnostic stewardship is a challenge, especially for microbiology labs, which are few in number. Cultures are done in few numbers. So this is, we are talking with NCDS, NCDC to upgrade our microbiology lab, give them the trainings to the microbiology culture people so that we have a quality driven data. Then mass mobilization and awareness program, we have started a hand hygiene, so important if we want to restrict the use of antimicrobials. Hand hygiene is one of the important things. So we are doing a lot of things on digital, then digital engagements uh, uh, on a platform. Then public discourse is so important because lots of time is the pressure of public to write antimicrobials. So for that, it's so important that people should know. Even I will really say that our Prime Minister has also talked about there is a program called Man Ki Baat where he talked about the misuse of antimicrobials by public. He requested people not to use antimicrobials unnecessarily, only when prescribed by your doctors, only then use. That is a public platform he uses. I think that has really created awareness among, because when a topmost person on a public platform talking about antimicrobials, I will give credit to Indian Medical Association because they created such a awareness program where Prime Minister has to intervene and to say that yes, this is an important thing, and we must not use antimicrobials. Public should not use. They should not take from the pharmacies only and only when a doctor is giving the antimicrobials. So this should be given. So this is a great initiative of Indian Medical Association. For that, the Prime Minister himself has to come to talk about it. Then there is a public awareness campaign has been done through one of a very newspaper, this NDTV. There's a very good media house who created awareness along with Indian Medical Association, and a Dainik Jagran, a newspaper program, is a news magazine is there, which is widely read by the general public. 7 days they have put they talked about different aspect of antimicrobials. So important, I think, that kind of awareness which has been created through the help of medical doctors. That's a very, very great thing to do. So this is, we are again another program which we are going to start. I think everybody in their country should start a fellowship program on AMR, which is driven by Indian Medical Association based on our experience, based on the diseases which we have. On that basis, we are going to have a AMR fellowship program. Then youth empowerment, junior doctors networking we have. like you have in WMA, the similar WHO and WMA. Similarly, we have in our national medical associations have junior doctor networking, medical student networking. I'll say that medical students should also be involved. That is our experience, which says there should be a proper subject on this, and they are the one who are really going to get benefit and bring a change in the whole system. That's so important. And another very, very important, we found through our experience, we found lots of antimicrobials being used in agriculture, lots of antimicrobials being used in animals
Allah ya
and coming into the environment
yes
also.
Allah
So,
kweli
so So I think this is most of your other countries must be experiencing that. That is what we found, and now we are creating awareness and a campaign with our these veterinary doctors, agriculture people, then through the environment also. Another campaign which we have started is a very innovative thing which we have started because there are so many antimicrobials which were left out, which are not used. They remain in house, and what has been seen is they are being thrown away into the drain, and through which it is coming into the environment. And that's a very important issue for causing antimicrobial resistance. So we have created a system now. We are trying to create a system with the government of India that it should go. There certain places will be there where the people can give their antimicrobials, and proper disposal of these antimicrobials will be there through a biomedical waste system. That is one thing which we are starting. So antibiotic timeout sticker, that is one other we have started at 48 hours or 72 hours when the report comes, there will be a timeout, antibiotics timeout stickers will be wherever the culture is being taken up. There, the timeout sticker will be there, and they have to see once that sticker is there, people will try to remove it when the report comes. So it's just a reminder is important. Green, yellow, and red aware list in the pharmacy. We are trying to keep that all the pharmacies should have green, yellow, and red, and they just uh, emphasize to doctors also, to people also, that green should be taken up more important rather than yellow and red. So these kind of things are there for our people. We are trying our best for that. Mm, we uh, we are trying to have amongst the resident doctors the stewardship program. We are asking them to reduce this. There was another thing which we found in India was people
Dr.
were,
Saini,
yeah.
sorry to interrupt. If you can probably just wrap up with this last idea
Okay,
in the last
okay.
minute.
Just this is
Yes.
almost
Sorry
finished.
to
This is
interrupt.
almost finished. Summary of a practical steps. So locate your local antibiogram, order culture correctly, review every antibiotic at 48 hours, teach one junior intern about AMR classification. This is this is all the stakeholders. Our AMR control requires coordinated actions from clinicians, laboratories, healthcare workers, pharmacy, policymakers, NGOs, and more important, public. So, and you young doctors, together we always win. Thank you so much.
Thank you so much, Professor Saini. I think you have outlined pretty clearly how junior doctors can also engage. I will give the floor also to Olayinka for our next speaker.
Thank you. So our next speaker is Sarah Torba, and she'll be talking to us about the role of surveillance. So we're talking about glass now, going properly into glass. And we're going to be talking about how the global antimicrobial resistance and the use of surveillance systems as glass can support countries in monitoring antimicrobial resistance and also informing clinical and policy decisions, and what are the main challenges and limitations faced in its implementation and use. So I'll be reading a bio now. So Sarah Torba is an epidemiologist and public health professional, currently working as AMR technical officer at the WHO headquarters in Geneva. She supports countries in strengthening national surveillance systems for antimicrobial resistance through global antimicrobial resistance surveillance system GLASS. Her work focuses on data quality improvement, capacity building, and facilitating timely reporting and validation of AMR data across regions. Sarah has a strong interest in evidence-based surveillance, One Health approaches, and operational public health solutions that improve data use for policy and action. She's passionate about supporting countries to translate surveillance findings into impactful public health interventions. The floor is all yours, Sarah.
Thanks, and thanks for inviting me today. Just 1 second to share my slide. Can you see my screen?
Yes,
Yes.
we can.
Yes. Okay, just okay. So good afternoon, everyone. Today I will introduce you to the role of surveillance system in addressing antimicrobial resistance, and specifically the Global Antimicrobial Resistance Surveillance, or GLAS, coordinated by WHO. So I think, as you may know, AMR is one of the biggest global health threats today. However, before we can respond to it effectively, we need good, high-quality data to understand where resistance occurs, how it spreads, and how it evolves over time. So this is where surveillance systems such as GLAS become essential. And let's start by understanding what GLAS actually is. So first of all, GLAS, or Global Antimicrobial Resistance Surveillance System, is the first global system to incorporate official national data from surveillance of AMR using a standardized approach, One Health model, and generate data to inform AMR burden estimates. The initial focus was on bacterial infections in humans. GLAS has 4 key components. The first one is the routine AMR surveillance system, which gathers national data from patients seeking care in healthcare facilities with suspected infections who undergo bacteriological and antimicrobial susceptibility testing. And the second one, the national representative AMR surveys, which measures AMR prevalence, mortality, healthcare costs in settings with limited microbiology testing. And the third one, integrated AMR surveys across the 3 sectors, human, animal, and the environment sectors, which are referred to as tri-cycle project. And finally, GLAS ERA module, which is designed to detect novel AMR mechanisms or unusual phenotype. Today, we will focus on the first component, routine AMR surveillance or national surveillance system, highlighting the national AMR data through routine testing. The main objectives of GLAS to support countries in building their national AMR surveillance system, with the main aims to harmonize surveillance across countries, guide empirical treatment guidelines, also to detect emerging resistance, support infection prevention, antimicrobial stewardship programs, as Deborah just mentioned, and of course inform research and development of new diagnostics. And for medical doctors, for clinicians, this type of surveillance data helps ensure that treatment guidelines reflect the resistance pattern that actually exists in their healthcare facilities. So to do this effectively, GLAS collects standardized surveillance data from participating countries. How GLAS works? GLAS works by connecting local laboratory data to global surveillance. So first of all, hospitals generate data through routine AST testing, soil antimicrobial susceptibility testing, and these data are compiled because it might be from different surveillance sites, compiled at the national level following standardized reporting methods, and then countries submit this data to WHO GLAS platform, where they are analyzed to identify global resistance trends. Finally, this analysis helps inform clinical guidelines, national action plans, and international AMR strategies. What data GLAS collects? So in GLAS routine surveillance, GLASS collects data from patients seeking care in healthcare facilities with clinical samples tested. GLASS requesting data on epidemiological, clinical, demographic patient data, besides AST, of course, and microbiology results. Currently, GLASS focuses on 3 bacterial pathogens. As you can see in this table, we are collecting data from 13 bacterial pathogens plus Candida, 9 specimen types, and 32 antibiotics across multiple classes. And since its launch, participation in GLASS has grown significantly. So country participation has grown from 100, has grown over time. Currently, we have 101 countries reported 2023 data, compared to only 25 countries in 2016 when we launched the GLASS. So it's like 300 increase over time. And it's worth to mention here that upward trend reflects increased awareness in countries of the value of sharing data from AMR surveillance as a common public health good. But again, beyond participation, another important question is the quality and the coverage of surveillance data, and we are going to talk about this after a few slides. So using data generated by through GLASS IT platform and the GLASS modules, we collected like more than 23 million infections reported from 104 countries, and the latest GLASS report highlights several important findings that we are going to go through. And this GLASS report actually is not just a document, it's a tool that should be used at national, regional, and global level, guiding context-specific interventions. And from our side, to ensure every stakeholder, every policymakers, researchers, clinicians, and the public can act on this information, the main report is accompanied by a very unique supporting materials like executive summary, flashcards, GLASS dashboard, and all the clinicians, policymakers could use these information to advocate and to implement specific interventions. So as I just mentioned, the GLASS report is like a global alert, and these figures demand immediate coordinated actions, as we are going to see. So we have like 5 key messages that we concluded from the analysis of the previous data, AMR data submitted to GLASS. The first one, since 2016, 110 countries, including the 3 areas, have submitted AMR data to GLASS. And GLASS now has reached a level of maturity that allows generation of global estimates. But however, the graph also, if you can see the graph also highlights an important challenge that we can see regional gaps still persist, and some regions have stronger surveillance systems and contribute more data than otherwise. Other regions are still building their laboratory and reporting capacity. So what is the priority action here? So to address these gaps, we aim to increase global coverage by expanding the number of countries contributing data to global surveillance in all WHO regions, and countries should ensure timely sharing of national AMR data to GLASS by 2030 in line with the declarations, the United Nations General Assembly political declaration, and also countries should overcome structured and operational barriers to data collection. And also it's very important here to emphasize that priority should be given to increasing participation in underrepresented regions. For example, we have the region for Americas. We only have like 8 countries submitted data to GLASS from this region, compared to another region like EMRU or EURU, that almost 100% of countries submitted data. The second key message, that global levels of resistance are high and unevenly distributed across regions, and the analysis of the extent of resistance in 93 infection type pathogen antibiotic combinations indicate a global pattern of AMR characterized by widespread resistance to essential first choice and second choice and last resort antibiotics. By analyzing 2023 data, on average, about 1 in 6 bloodstream infections are caused by resistant bacteria, and resistance was most frequent in Southeast Asia and Eastern Mediterranean region, almost 1 in 3 infections, followed by African region. You can see here also that 1 in 3. Okay, so you can see here that median resistance was most common in urinary tract infections, approximately 1 in 3, and the bloodstream infections 1 in 6, and less common in gastrointestinal infections, which is 1 in 50. Again, what is the priority action? What is the priority action here? To tackle high level of antimicrobial resistance, countries should implement integrated intervention packages supported by AMR data, awareness, education, and these packages should include, of course, as Deborah mentioned, antimicrobial stewardship, infection prevention and control, water sanitation and hygiene, strengthening laboratory services aligned with WHO-centered approach, and these interventions should be integrated with multi-sectorial national AMR action plan. And again, it's very important that these interventions should be tailored to local resistance pattern and health systems capacity. And we should avoid a one-size-fits-all approach. Each country should adapt their own intervention package according to their situation, context, and generated AMR data. The next key message, trends in AMR indicate an increasing threat from gram-negative bacterial pathogens, as you can see in the figure in the screen now, and resistance to watch antibiotics in the aware system, particularly to carbapenems, fluoroquinolone, is increasing among key gram-negative pathogens like Acinetobacter E. coli, Klebsiella, and Salmonella. So rising AMR is limiting the empirical therapeutic choices and driving a shift from oral to intravenous treatments, including greater dependence on second choice and last resort antibiotics. Yeah, as you can see here. And also this data shows us that there's an annual relative increase ranging from 5 to 15, depending on the combination. The next few slides, okay, show examples of important resistance pathogens monitored by GLASS. Many drug-resistant pathogens are associated with severe clinical outcomes, limited therapeutic options, limited preventability, and are characterized by high incidence and morbidity. For example, E. coli is a major cause of community and hospital-acquired urinary tract infection and the bloodstream infections as well. So resistance is due largely to production of ESBL, which limit the effectiveness of commonly used antibiotics. And as you can see the figures here, global resistance third generation cephalosporin, first choice treatment of bloodstream and complicated urinary tract, at 45 of bloodstream and 40 of urinary tract E. coli infections. The second one, carbapenem-resistant Klebsiella, is a major cause of hospital-acquired infections, especially in intensive care and surgical settings. And based on 2023 data, the percentage resistance to imipenem was 17% globally. Carbapenem-resistant Acinetobacter also is a hard-to-kill ICU pathogen that survives on surfaces and resists nearly all antibiotics. So it's frequently implicated in hospital-acquired bloodstream infections, especially in critically ill patients and immunocompromised patients. And also you can see here that another important pathogen, Neisseria gonorrhea, is a sexually transmitted pathogen with high global incidence, and resistance to Neisseria gonorrhea based on data generated by GLASS has emerged for every drug available for empirical first-line treatment. What is the priority action here? Countries should optimize antibiotic use to tackle increasing resistance trends in gram-negative bacterial pathogens, and they should generate robust nationally representative AMR surveillance data to guide evidence-based empirical antibiotic guidelines, of course. Also, they should reduce use of watch antibiotic, increase use of access antibiotics at least 70% by 2030. And also at the same time, the country should also organize the next recourse to treatment by extending access while ensuring prudent use of reserve antibiotics. The fourth key message, and this is also very important, we noticed from the data we analyzed from class, settings with lower AMR surveillance coverage report higher levels of AMR. So again, this pattern may also reflect biases in the data, such as selective sampling in tertiary hospitals or of severe cases only. And to tackle this one, the recommendation is for countries to integrate surveillance into routine clinical practice and develop systems that can generate representative national AMR data across all healthcare levels, across all infection origin, for all class pathogens, and based on individual patient level reporting in accordance with GLASS standard. And of course, to achieve this, countries must expand access to quality assured bacteriology and mycology diagnostic across all tiers of care. The last key message that we notice, socioeconomic factors and the strength of health systems are key determinants of the AMR burden. And AMR disproportionately affects countries with lower income and fragile health systems. In fact, there's a strong inverse, as you can see here in the figure, in the graph in front of you, there's a strong inverse correlation between the universal health coverage service coverage index of a country represented by a dot in the plot, these dots, and the income classification of the country and the national median percentage of AMR in bacterial bloodstream infections. Again, what is the priority? What is the priority action here? To strengthen health system and improve equity. And to address AMR, countries should implement a broader strategy that strengthen health system, enhance resilience, and prepare for emergencies. So despite major progress in GLASS, there are several challenges in global AMR surveillance. First, incomplete global coverage. Many countries still don't report data. And secondly, limited laboratory capacity in some regions, as I just mentioned. And also there are differences in surveillance design and testing standard across countries. Also regarding data quality and the completeness, there are missing metadata or inconsistent reporting across countries. All these challenges in GLASS AMR surveillance system, and also we have to acknowledge the limitations in interpreting GLASS data. Aggregate data, for example, because the GLASS is still collecting aggregate data, and we are moving away from collecting aggregate data to collect isolate-based patient data. But again, this aggregate data reporting limits detailed epidemiological analysis and modeling. Potential reporting bias, as countries with strong surveillance systems are more likely to report. Time lag between data collection, validation, and the publication. Also, this is one of the limitations in interpreting GLASS data. For example, we analyzed the 2023 data and published this, the analysis of this data in 2025. The final key messages: AMR surveillance is essential for evidence-based treatment. GLASS provides a global picture of resistance trends. And of course, better surveillance leads to better clinical decisions and policies. And lastly, strengthening surveillance systems is critical to protect antibiotics for future generations. Thanks.
Thank you so much, dear Sarah. I think you have outlined really well from the global perspective, also what's the work from the whole GLASS surveillance system, as well as these 5 key actions or priorities. So as we have come short with time, I would like also our three speakers, if possible, probably just to give this concluding message in a short way, also more focusing on a positive way for our junior doctors, which opportunity or probably which message you would like to leave to junior doctors as an opportunity to engage, even though it can be from antimicrobial stewardship, from the surveillance in a global level or in a national level. Which message of as an opportunity for junior doctors to engage on these topics would you give? So I would like to invite our three speakers if they would like to give a short also message for also closing today's discussion. So probably, as I see you, Sarah, already with your camera, I see also Deborah here. Probably, Deborah, would you like to go first?
Sure. I guess my message for all of you today is thanks very much, first of all, for your interest in the topic. And I think every single one of you can make a difference in terms of antimicrobial stewardship, improving the use of antimicrobials, and to mitigate the emergence and spread of AMR. So I think hopefully with a little bit of additional knowledge, you go out there in your practice and really consider every time you are prescribing an antimicrobial, whether it's needed in the first place and how best we can improve our patient outcomes with the most appropriate antibiotic and to help preserve the usefulness of our agents for the future. Thanks.
Thank you so much, Deborah. I see also Dr. Saini that is, even though on the travel, I see that he's also connected. So if you would like to go next.
Okay, I'll just say that, as I said before, young doctors are the face of medical profession. They are the one who are going to drive the antibiotic stewardship program because they are the one who are writing antimicrobials at the first instance. So if the first instance is right, then everything will be right. So please follow the AMR aware list properly. Properly follow the escalation and de-escalation metrics. That is and document it. The one habit which is not there is documentation and infection control practices, hand hygiene to prevent to use of antibiotics. So hand hygiene is one of the most important thing. That's the message I want to give you.
Thank you so much, Professor Saini. Sarah, would you like to also answer this question?
Sorry?
Yes, would you like to go then for this final remark on the opportunity for junior doctors?
Of course, thanks for joining. Thanks for listening. And I think Deborah and Dr. Nazia have said everything, but I may emphasize the role of surveillance systems at the facility level, the use of data generated by the surveillance system, and of course, your role as future doctor in responsible antibiotic prescribing, infection prevention, supporting surveillance system will be essential to preserving the effectiveness of antibiotics for future generations. So yeah, this is my final message to you.
Thank you so much, Sarah. Unfortunately, also Olayinka cannot now speak, but that she didn't open a space. But we're really excited also that we managed to also make this space for having experts, global experts, and really highly recognized internationally from the AMR world, especially talking with our junior doctors, both those who are now online, but those who also see the recording afterwards. So thank you all for joining also today's webinar on antimicrobial stewardship and antimicrobial resistance and surveillance. As junior doctors on the front lines, you have the power also to make a real difference by implementing this WHO's AWARE framework, following evidence-based prescribing practices, and contributing also to surveillance systems like GLASS. So let's commit to being responsible stewards of antibiotics and also protecting these vital medicines for future generations while improving also patients' outcomes today. So we will close it here, the webinar, also, as we are already over time. But we thank everyone for joining, especially our esteemed speakers for coming to this first space from this Junior Doctors Network AMR working group space. So hope to see you in another occasion, and thank you a lot again for your time.
Thank you. Bye.
Thanks.
Thank you.
Bye.
Thank
Thank
you.
you. Bye.
Bye.
Thank you.